This session, week 7, is on nutrition, and you had some good readings for it to look at. And I decided I would do this lecture focusing on obesity. It's for a couple of reasons. One is it's probably the biggest nutritional health problem we have in the United States, certainly not worldwide, because there are places where people don't get enough food or enough nutritious food. But in the U.S., in the Western world, and in the developed countries, obesity is becoming a tremendous health risk for people, and it's also something that I know more about than I do other things in nutrition, because I did my DMP project on the general topic of why do primary care practitioners fail to follow evidence-based guidelines when treating their patients. So with that said, we'll get started. I have you guys muted, so if you want to speak, you might have to unmute yourself. Feel free to do that. Also use the chat room, and I'll try to remember to watch for chats as they come in. So let's get started. I'm gonna share my screen now. Oh. Good, there we go. So here we are, module 7. Can you all hear me? Just kind of nod if you have your, okay, good. The objectives for today are to discuss the role of nutrition as a component for the practice of nurse practitioners, describe the relationship between nutrition and commonly occurring problems such as obesity, identify effective methods for integrating concepts of sound nutrition into areas of practice for nurse practitioners, and to demonstrate evidence-based methods to assess and treat common nutritionally related outcomes. So for today, we're going to talk about obesity. And you had these other readings. The Hark, Ashton, and Dean textbook addresses most of the problems you'll encounter in practice and gives a good overview. And today we're going to use overweight and obesity assessment and treatment as a model for addressing nutritional issues in patients. The processes, concepts, and approaches to effective in overweight and obesity management are transferable to other nutritionally related health problems. So if you look at Healthy People 2030, which is not actually a lot different than Healthy People 2020, which the course has references to, they released 2030, I think, within the past year or so. Obesity plays out in that pretty prominently in a couple of ways. Overweight and obesity objectives have their own section, and in general, it is to reduce the portion of children and adolescents with obesity. We have some content coming up in the presentation on that. The increase in obesity in kids is alarming, to say the least. And then diabetes, to reduce the portion of adults who don't know they have prediabetes, which is considerable, and increase the proportion of eligible people completing the CDC recognized, misspelled there, sorry, type 2 diabetes prevention programs. And there are some good ones out there. The one that I use in my own practice and used in my DMP project is called Prevent T2. Google that if you want to get some really great, useful tools for your patients when you're working with them and helping them attain a healthier weight. Other overweight and obesity objectives in 2030, in Healthy People 2030, relate to healthy eating and nutrition, and that's to reduce the proportion of adults with obesity, increase the proportion of healthcare visits by adults with obesity that include counseling on weight loss, nutrition, and physical activity, to reduce consumption of added sugars by people aged 2 years and over. And then they're in their section on pregnancy and childbirth, they address obesity and eating again to increase the proportion of women who had a healthy weight before pregnancy. I just want to point that out. Remember that, because it's going to come up later when we talk about epigenetics. This is critically important, And it's just recently, within the past decade, even come into focus that the weight of women during pregnancy has a real impact on their offspring and their weight situation throughout their lives. And then in nutrition and general eating, you can refer to the webpage, but there is some information there as well. The other thing I want to tell you is that there are a lot of slides here, and I'm going to move fast to get through them. Don't be anxious about trying to memorize this information, and the slides are out there for you. It's a high level for what you're going to need in terms of the course or the test at the end. Don't worry about that. Just try to listen to the story here about obesity and the things you have to do to be effective as a caregiver, as a provider for patients with overweight and obesity based on what we know in the current evidence. So just kind of relax, watch the show, raise questions as you need to. And again, if I missed that you put something in the chat, just feel free to unmute yourself and call out to me, okay? So overweight and obesity in primary care. Overweight and obesity are, without question, the most prevalent nutrition-related problems seen in the US in primary care, and they're very often ignored. Assessments and treatments of overweight and obesity are just not consistent with the state of the science. And that's more than opinion. There's a ton of evidence. People have studied it. For example, what I'm talking about is if somebody comes in and they're hypertensive, we, as providers, collectively, we just go right to the 2017 guidelines. We just start taking care of their hypertension. We start, diet modification, lifestyle, meds, just kind of get right into it. And insurance companies look to see that this is happening in terms of their quality screens. I mean, there's a whole system to make sure. I'm just picking on hypertension, but pick anything, ischemic heart disease, whatever. We just go right to the guidelines and start doing it. But we look at people with obesity and we just ignore it. I mean, as a group. And that was the thing that triggered me to do my DNP project. Is why do we do that? So anyway, let's talk a bit about the epidemiology. The prevalence is high, 34.9%. This was a 2014 number. It's been pretty flat. It hasn't been skyrocketing, but it's on a consistent upward trend. So it's going to be a little higher than 35% now. Obesity, through the course of this presentation, will mean BMIs over 35 and overweight up to 35. So that's kind of what we're talking about. Depending on the author and the group and the professional group, those breakpoints may vary a little bit. What they really relate to is when does your cardiovascular risk and your cancer risk start to change? And the best evidence, we used to think it was 30. We think it's more based on a big study in Norway a few years ago. It's probably all higher than that. It's probably about 32.5 to 35 before you really start seeing a change in your risk factors for comorbid conditions. World Health Organization predicted worldwide obesity to be 41%, and obesity and overweight combined to be 75% in the world by 2015. And that seems to have been a prediction. They made that prediction way back in 2006, and that seems to have been true. So what about prevalence by gender? Well, in this slide, men are the gray and women are the darker gray. Men are more overweight and obese overall than women, kind of equal at the obesity, but extreme obesity. So BMI is over 40 for 45, sometimes called morbid obesity, higher in women. Prevalence of overweight and obesity in children and adolescents in the US is a real sad story. US obesity in children is 18% and in adolescents is 21%. And these rates have tripled from 1980 to 2012. And you can see it's broken down here for ages 6 to 11, the rate increased from 7% to 18%. And for ages 12 to 19, it increased from 5 to 21% in that period of time. So this is just a chart showing a kind of the obesity trends from 1961 to 2009. And as I was telling you, the more current chart, while you see this little dip coming down here a little bit, this is continued onward. And so we're looking now upwards around 35% for obese. And the very obese, BMIs over 40, kind of the same line, but maybe has trended down a little bit, not down, but flat. The trend line flattened a little bit. This just shows you a demonstration across the country. So to orient you to this chart, this is 1990, 2000, and 2010. And then the scale here is by color. So the light zeros, we just don't, or the white, we don't have any data. This lighter blue color would be less than 10% of the population as being obese, a BMI of over 30. And then all the way out here to the dark color, which you can't see here. Oh, I'm sorry. See if I can get back to it. Yeah, you can't see, but that's where you're greater than 30%. Look what's happened in this period of time. So I don't have a new map to show you for 2020, but just follow the same concept. That the trend line, it continues to go up, although the rate of increase, thankfully, in the last decade has flattened a bit for reasons that aren't really entirely clear. But it's just really growing fast. That's the big take home there. And then here, self-reported obesity among US adults in 2015. This is a geographic spread. And you see red states as being in the 30 to 35. The dark red are over 35. And that's a third of the population is either obese or very obese. It's frightening, to say the least. Well, what's the significance of being obese? Well, it ranks only second to tobacco in health behavior related causes of death, consequential in terms of disease, disability, and financial burden, chronic relapsing condition that has strong familial tendencies, and the US financial impact is estimated in this year, 2016, to be between 147 and 190 billion dollars per year, and that's in medical costs alone. So they haven't considered in that number lost work, lost income, other financial consequences of having a population with high obesity. It's just the healthcare related to high obesity. Oops, not a very good slide here. Sorry, I didn't catch it, but this just shows you the comorbid conditions. Well, we all know about type 2 diabetes, but asthma is made worse. Sleep apnea, hypertension, stroke, and other illnesses, osteoarthritis, gallbladder disease, gout, infertility, and 11 cancers are directly related to obesity. In other words, the risk for them increases as a result of an elevated BMI. And what are the causes and the pathophysiology of overweight and obesity? There are a lot. Genetics is a contributor in 40 to 70% of the cases. But hold that thought because we're going to come back to it. Pharmaceuticals like corticosteroids, antidepressants, and anti-seizure meds contribute. Endocrine diseases other than obesity, like hypothyroidism, Cushing's, and polycystic ovarian syndrome, play a role. A sedentary lifestyle is a major component. Consumption of high energy dense foods. Is probably of everything why we're seeing this increased rate is the way we eat differently over the last 35 years in the US. Insufficient sleep. Stress is big, and a disturbed gut flora has been examined and was at first thought to be really important, and more current literature suggests that while it is playing a role, it may not be as large as we at one time thought. Here's something to look at. Now, I talked about high calorie density foods being chosen more often and contributing to obesity. There's this guy Lustig. He's a pediatrician by background, but has great credentials, good researcher, very credible person. And he's been kind of on a crusade, if you will, to get rid of high fructose corn syrup in the US diet. He says high fructose corn syrup is poison. And in fact, he's probably right, depending on your definition of a poison. So what we see here, and his big deal is, look at the trend line for obesity. That's the blue one, and very obesity. And now look at how it is mirrored by the consumption of high fructose corn syrup by the US population. That's not, that didn't just happen. That happened, this is a public policy issue. Here's what happened about the consumption of high fructose corn syrup. So it's all here about 1980. In the 70s and late 70s and early 80s, there was a situation where the corn farmers of the United States found that they had lost markets, international markets for their products, and they were finding surpluses and very depressed prices for their corn products. They have a strong lobby. The lobby went to the FDA, and they got them to change FDA rules to suggest that fat, they actually went at it not by saying you should put more corn syrup in things. What they went at was to say we should get saturated fats out of the US diet. We should make that happen, knowing what would happen next, or at least suspecting. So there were new standards brought in around that time by the Food and Drug Administration to labeling about high polysaturated fats and fat content in general, and new standards for processed foods and fat content. All this no fat, no fat, no fat. And if you're of my age, you will remember probably that. You'll relate to that, because all of a sudden we were getting lots of products that were branded as low fat, no fat, like salad dressings and things that you generally don't expect had a lot of fat. What was going on behind the scenes is they were replacing, when you take the fat out of those products, they don't taste very good. So the thing that they replaced them with was high fructose corn syrup. And now we see large amounts of high fructose corn syrup put into all kinds of processed foods. And the problem with high fructose corn syrup is that it is very, very absorbable in an enormously fast rate. When you swallow that stuff, it is absorbed very, very quickly through your gut, and it overwhelms your liver's ability to normally process the carbohydrate. And the default thing that your liver has to do with that bolus of carbohydrate that it's seeing with high fructose corn syrup is convert it to fat. It can't make it into glycogen. It can't store it in other ways. It can't use it in processing for other chemicals and so forth in our body. So it just turns it to fat. And that's what happened. So the corn lobby got fat out of the American diet, replaced it with high fructose corn syrup, and boy, there you go. So in terms of health promotion, public policy is a big deal. And here's a really sad example. Okay, what else? Causes of obesity in biological, environmental, and social. Going the wrong way. So in terms of classic Mendelian genetics, that is changes to the DNA, it does not contribute more than about 5%. A very small portion of people with traditional Mendelian genetic inheritance have problems with weight control. And these are the diseases. The one that probably most people are familiar with is Prader-Willi. Those are the kids that are just hugely obese, and they have unbelievably powerful cravings for food. You hear stories that like the families have to put locks and chains on the cabinets in the refrigerator to keep the kids away from food. That's Prader-Willi. Really tiny percentage of the population, maybe less than 1/3%. But when you put them all together, there are others, as you see here on the slide. When you put them all together, they're only about 5%. But we know that genetic causes are much bigger than that. And the big one is epigenetics. So what is that? Well, epigenetics can be defined as heritable, in other words, inheritable changes in gene expression that happen without changes to the actual DNA molecule. And there was a realization that there were forms of heritability or genetic environment interactions that could not be accounted for by classic genetic principles that was described in the 40s. Yet it was not until the 70s that we first began to understand what epigenetic molecular changes were about, and DNA methylation and acetylation are the two major ways that happens. And there's yet a great deal to be discovered. Now, this is a video that I've just, in preparing, sitting down right now to give you the lecture. I don't think I can run it anyway. I don't think you could hear it. Let's see if you do. Can you hear that? Yeah, I think so. It's an excellent little video. We're going to move right past it. It talks about, it's a great thing on, and what I'm going to do with it is just post the video out into the course shell. So you come back and look at it if you're interested. If you ever heard epigenetics, weren't really sure what it's about, this 11-minute video is excellent. The other thing about this video is they talk about agouti mice. And the agouti mice is a model used in genetics frequently. So here's the story. They're just little mice, but they're cloned, so they're genetically identical. And the normal agouti mouse is kind of a gray color, like a mouse would be. And then there's this variant expression. They're genetically the same, but a variant expression of a tan mouse that is obese. And what they found was, and here's the big take-home message for our course today, if they fed mothers, normal-looking gray mothers, a certain kind of food, which was very high in calories, while they were pregnant, their offspring were the tan agouti mice that were obese. And that's when we really got an understanding of the importance of nutrition in pregnant women, or even pre-pregnant women. And it's because that change in the expression of the gene happens because of this high calorie environment in the body. And so go back and look at it. We just aren't going to watch it here today. So what about epigenetic mechanisms? Well, there are three main types of epigenetic modification in mammals, including, of course, humans, and they are molecular processes related to DNA molecule structure and gene replication. And the three are acetylation, methylation, and non-coding RNA, which is the lesser of the two. Methylation and acetylation are the most important. And what you're going to see in that video is basically through methylation and acetylation, you have these long strands of DNA called chromosomes, and there are places where other molecules can sit on top of those codons and top of the parts of the DNA molecule that is transcribed, the gene, and it will block them, it will turn them off. Through acetylation and methylation, that changes the way they wrap around histones, other proteins. You may remember this from, I imagine you heard this from Dr. P or somebody else. The way that they're wrapped around proteins called histones, or even the way that certain other molecules called disruptors sit on top of the DNA strands, changes the expression of our DNA. That's epigenetics. So, over under nutrition during pregnancy and lactation is a big portion of probably what's causing this ongoing upward curve on obesity. And then there's endocrine disrupting chemicals, or EDCs, that may be impacting the epigenetic changes. And the other thing to know is, while you would maybe intuitively think that the changes, epigenetic changes, would just be in the current generation, they wouldn't be transferred to the offspring, but they are. There is transgenerational inheritance through stable markings that persist right through meiosis and mitosis, well, meiosis in particular. And here's an example of a disrupting chemical, transgenerational influences. So these EDCs come in and sit on the chromosomes, as you see here, and change this expression. So that it isn't necessarily just acetylation and methylation, but there can be environmental chemicals that can have the same impact. And here are some examples of EDC disruptors: diethylstilbestrol, the bisphenol A. These are going to look familiar to you. DEET, the pesticide, phthalates, and so forth. And these are now hopefully being better regulated than they were in the past, but they're still in the environment and they can still have an impact. Examples of disruptors that aren't EDCs include folate, oddly enough, high-fat diet, dietary caloric restrictions, stress, smoking, and ethyl alcohol, all demonstrated to be endocrine disruptors. Clinical indications for epigenetic mediated obesity risk is internal and external environmental exposures will create heritable changes. So heritable, again, means those that can be passed on to future generations. In gene expression that impact adiposity and related metabolic states. There are periods in human development that are most vulnerable to epigenetic disruption. And epigenetics may offer a path to improving obesity on an individual level to stem the epidemic of obesity on a population level. All right, let's talk about obesity as a disease, because a lot of us think of fat tissue as just kind of a warehouse to store calories. I think that's what I had thought of for a long time. It's not. Adipose tissue is an enormously complex endocrine organ. It has lots going on in there. It is not just a warehouse. So when you begin to peel back that onion, you get a much better understanding of what this disease of obesity really looks like. So through data collection, evaluation, assessment, management decisions, we as clinicians need to take that science and then bring it to patients either in populations or an individual basis through health promotional activities to help them achieve a better health status related to their body weight. So what about assessment and treatment? It's a multifactorial disease: environment, immunity, endocrine, medical, neurobehavioral, and genetics and epigenetics. Immune is mostly related to inflammation, is a big component in many forms of obesity. The obesity etiological issues include the genetics, as we've talked about, and the extragenetics, which would be environment, culture, lack of optimal nutrition and physical activity, adverse experiences of medications, adverse reactions to meds, neurological dysfunction, viral infections, and then the gut microbiota that we talked about earlier. Pre-pregnancy is a big one of those areas where the epigenetic impacts can be most important. And this slide just shows you pre-pregnancy, pregnancy, and post-pregnancy, but there are all of these things. Now, remember when we looked at Healthy People 2030 and they focused in on the nutrition of women during pregnancy, it relates to this phenomena, okay? Within the subsets of patients with obesity or overweight, there's kind of two groups. And I'm going to refer to this going forward. So this is just kind of an orientation slide. There's the group with a sick fat disease. And now the language being seen in the literature is adiposopathy. So these are where there really is a metabolic derangement going on within the adipose tissue, that we aren't seeing the normal hormonal function that happens in people. It changes. And then on the other side is the fat mass disease. And that is the biomechanical and structural changes that happen, kind of the consequences of carrying around too much weight. And this shows you some of them here that are common to all of us who've treated patients with an overweight or obesity problem. So what should be the overall management goals? Well, adult patients with overweight or obesity, we want to improve their health, improve the quality of life, and improve weight and composition. Let's talk just a second about BMI. So that's a really crude indicator. It isn't very, very good on an individual basis, but it's quick and easy. And you can use it for kind of describing kind of groupings of people in a continuum of low body weight, healthy body weight, and then higher into overweight and obesity. And this just shows you the range. The cutoff points may be more appropriate for women versus men and some races and ethnicities. The other thing is that it doesn't really account for the composition of that weight. For example, I practice, part of my practice involves the campus health center at Wayne State University, where we have a young population. And now because of COVID and so forth, we see a lot of athletes because they come in for testing and that sort of thing. These athletic men and women come in with fairly high BMIs, but they have a very low percent body fat. Does that make sense? So BMI is pretty crude. You got to be careful about that. And when you're individually managing people, BMI is not really going to be something you want to work with a whole lot. You're going to want to zero in on things like my favorite, waist circumference, a much more accurate depiction of what somebody's real situation in terms of fat content in their body is. And so here's the percent body fat, which just kind of shows you with athletes, fitness, acceptable obesity, and so forth. And we'd like to see people generally to be around 15 to 20% body weight. The really hard trained athletes, maybe under 10. it can be a little dangerous to be that low in terms of some of the problems I have with even like suspension of your kidneys and different things. You need more body fat than that to have normal function. Yet also, if you get sick, you don't have any reserves. So we're not going to be proponents of people getting under 10 or 12%, but 12 to 15 would be ideal for most of us. And then here we are with waist circumference classifications. And so for men, it's a waist circumference of over 40. Now that doesn't mean your pant size. You have to really take the measurement at the umbilicus above the iliac crest to get the right one, because you know how people's bellies develop over time. You tend to sag, but when you measure too low, you can get under the fat apron and get a false low reading. So you really do need to take the measurement correctly and not, for example, take self-report that I wear a 35-inch waist pant, when in fact your circumference, if you measure it at the right place, might be upwards of 40, or it might not, but it could be. So there you see those. Okay, so now we're just going to go through some of the indexes. I'm going to go quick. I think we've talked about this. BMI, quick and easy, commonly used, easily reproducible, low cost, used in a lot of epidemiological studies, and it's okay for screening. The disadvantages are the ones I've already talked about. The cutoff points may not distinguish between men and women or ethnic racial people very well, does not account for muscle mass and so forth. But the idea is that the only reason we really care about BMI or waist circumference or anything else is what is it doing to their risk for disease? That's really what we want to know. And it looks like cardiovascular risk is going to start going up at about 32%. Body fat, I think we've talked about that. Waist circumference, we're just going to move along because I talked about that. So what's the best measure? Well, for a population assessment, body mass index, waist circumference, and percent body fat similarly correlate with the prevalence of metabolic syndrome. Metabolic syndrome being type 2 diabetes, overweight, hypertension. And so you can use it at a population level. On an individual assessment, BMI is fine for screening, but once you're going to manage somebody, you really want to get better measures. So percent body fat, the ideal way to do that is to immerse them in water in a special tank with a scale, but how many of us have that opportunity? Probably tricep skin fold thickness is as good as anything you're going to need to get your percent body fat. That's a reliable enough method. Let's talk about fat mass disease. There are clinical manifestations of fat mass disease. So fat mass disease is just the effect of it, the effect of having all this fat in the body. Cardiovascular, we see congestive failure, cor pulmonale, varicose veins, thromboembolic disease, and hypertension. Pulmonary is dyspnea, not just Pickwickian, but that can be part of it. Obstructive sleep apnea is huge. If men have a neck circumference over 17 inches, they're at greatly increased risk for sleep apnea. And then even intracranial hypertension due to increased intra-abdominal pressure and sleep apnea, stroke, and nerve entrapment syndromes. And these are both in the upper and lower limbs. Immobility, osteoarthritis, back pain, impaired balance, reflux, hernias, the skin with stretch marks, face pigmentation, cellulitis, carbuncles. Other clinical manifestations include depression, hopelessness, self-esteem image, disruptions, diminished sex drive, impaired intimacy and sexual relationships. There are biases. There's a lot of stigma about being overweight in society, families, workplaces, harassment, bullying. There's a lot of negative outcomes here. Negative self or external perceptions. People see fat, lazy, fat, unmotivated, fat, less attractive, fat, overindulgent. This is not news for any of us. So that's the fat mass disease. What about the sick fat disease? The abnormal endocrine and immune responses that come with it. Well, impaired adipogenesis. I was talking about when you swallow a bunch of high fructose corn syrup that your liver has no choice but to just turn it into fat because it's coming so fast. It's like drinking from a fire hose. That's impaired adipogenesis. But there seems to be also in some people that they form fat more quickly than other people do. And other people would have other mechanisms of changing those carbohydrate molecules into things other than fats, like glycogen. They selectively try to keep making fat. Adipocyte organelle dysfunction, increased circulating free fatty acids. There's a pathogenic adipose tissue endocrine responses and pathogenic adipose tissue immune responses, pathogenic consequences to other organs, such as the fatty liver disease, vasculopathies, and hypercoagulation, different problems. Adipocyte hypertrophy. So it isn't just that there's more fat in the cells, but there are more fat cells. There's hypertrophy actually going on. Increased visceral, pericardium, perivascular areas. There's growth of adipose tissue beyond vascular supply. They get into necrotic stuff. Increased adipose tissue immune cells, and ectopic fat disposition into other areas, including the pancreas, in particular liver and muscle. So adiposopathy most often results in metabolic disease when it is accompanied by dysfunction of other organs, or limitations of metabolic flexibility of other organs to mitigate the pathogenic metabolic, endocrine, and immune responses promoted by obesity. Metabolic health is dependent upon the interactions or crosstalk with adipose tissue and other organs. So that's kind of the important central concept of adiposopathy, is it's not just in the fat cells, but there's in the normal homeostasis of an individual, there is an interaction that happens between the fat cells and the other tissue cells to control the availability of energy, and that gets disrupted. And these are some of the consequences for that. High blood pressure, high glucose, metabolic syndrome, adiposopathy, lipidemia, it's a mouthful, but it kind of shows you some of the stuff that they get. And you'll see this on some of you're going to pull lipid panels on people, and they're going to roughly look like what you expected, but people who are really, really overweight, some of them have very unusual HDL, LDL ratios. The ratios look protective, but you don't think that it's probably true. And partly that's this adiposopathic dyslipidemia. We don't have a lot of data on it yet, but I think we're going to see more. Insulin resistance, we're familiar with that with our type 2 diabetics, fatty livers, hyperuricemic and gout, cholelithiasis, acanthosis nigricans is a skin condition, usually seen at the areas, kind of the same place you get eczema, kind of in the creases and that sort of thing. I won't read them all to you, but you can see that there's just a lot of it. And then there's the gender-specific manifestations. Women with hyperandrogenemia, hirsutism. This looks like PCOS. It's listed here as one thing, but they all kind of fit together. Pre-gestational diabetes, preeclampsia, and thrombosis. And in men, hypoandrogenemia, hyperestrogenemia, erectile dysfunction, low sperm count, and fertility. All related, we think, to the adiposopathy. That is the hormonal activity going on in the fat cells that's impacting all of this other stuff. And the cancer manifestations. These are cancers directly related to high BMI. Sleep disorders are huge. And these are the histories you will see on that. I think many of you know probably a fair amount about this. It's pretty commonly understood. But obesity is a big component to that. Kind of obesity and the architecture of a person's pharynx. If you work in surgery or anesthesia, you'll be familiar with the Mallampati scores, 1 to 4, depending on the shape of the pharynx and how tall the pharynx is, between the tongue and the top of the hard palate in the back. That some people is really narrow. They would be on Mallampati 4. They are really at risk for sleep apnea. But you add to that extra fat, and you get into problems. Other physical findings, so I was saying 17 inches in men, 16 in women, had abnormalities, the Mellon-Potty scores, and other things here. I don't need to take you through the whole thing. These slides are out there if you want to come back and look at them later, but you can see that. Also, cardiopulmonary abnormalities are associated with sleep disorders, and high blood pressure is one that we're all familiar with, but also cardiac dysrhythmias, peripheral edema. This is really about sleep and obesity. The adverse consequences of untreated obstructive sleep apnea, worsening obesity, atrial fib, all kinds of problems. So sleep disorders and obesity obstructive treatment, fat weight loss is one of the things that we do to try to help people who have sleep apnea. Behavior therapy to improve sleep patterns, oral appliances, nasal positive airway, adaptive cerebral ventilation, the BiPAP kind of thing that people wear at night, the mask, and then surgery. What about stress and obesity? Both cause and effect. The stress response causes cognitive changes, increased in some cases of emergent stress or decreased in some cases of prolonged stress. Physiological changes, behavioral changes, and pain. Potential analgesia with emergent stress. You don't feel pain when you're under huge emergent stress, but then worsening with chronic stress. You're more sensitive to pain. The emergent fight or flight response, that increased sympathomimetic activity that happens, it's increased in the short term with sympathetic nervous system activation, but you also get increased catecholamines, norepinephrine and epinephrine. There's a cardiovascular response, we're all familiar with this, and then the metabolic responses in terms of obesity, we're very interested in this. You get an increase in glucose levels, increased insulin resistance, pushing your glucose levels up. Well, why would we want that? Because you want to, the thing that your brain needs, the only energy source your brain can use is glucose. It can't use fatty acids or other forms of energy. It's got to have glucose. So we think that the reason this was adaptive through evolution to make this happen is that when you're under really extreme, intense stress, you adjust the way you're using carbohydrates and energy sources in your body to push your blood sugar level up, to push as much glucose as possible into your brain where it's needed to help you figure out how to get out of your situation. The other thing is there's an increased adipose tissue lipolysis, which sounds like probably should be a good thing, right? Problem is, in chronic suppressive responses, increased hypothalamic activity along the pituitary axis, there's increased corticotropic releasing hormone, increased adrenal corticotropins, more arginine, vasopressin, oxytocin, and increased, here it is, blood cortisol. And that leads to the metabolic response to increased cortisol, a potential for increased glucose levels and increased glucose resistance over time, and increased hepatic gluconeogenesis, increased blood pressure, and increased adipose tissue lipolysis. Cortisol is a catabolic hormone. So the acute response, the catecholamine-mediated response, is immune effects can be mixed, but in general may enhance the immune response. Demargination of leukocytes from the vascular endothelia increases leukocyte blood concentration, increased innate immune responses, adaptive immune responses, T lymphocyte cytokine responses, but prolonged, the glucocorticoid-mediated ones, our immune effects are mixed, but in general may dysregulate immune responses. So you have fewer leukocyte mobilizations and decreased leukocyte blood concentrations and decreased innate immune responses, decreased adaptive immune responses, and a decreased T lymphocyte cytokine process. So why do we care about that? Well, all of that is going to change the way that you use energy. These are just the chronic psychological behaviors from stress. There's the limbic system, chronic stress-induced endocrinopathies and immunopathies, and then which would be your non-thought centers, the stuff that runs your metabolic organ system, so to speak, the limbic system. But then the cerebrum, where you're doing your thinking and perceiving, is changed as well, with priority placed on replacement for personal work or emotional priorities may overtake priorities relative to nutrition, physical activity, or health. There's a chronic stress-induced endocrinopathies and immunopathies that may adversely affect the cerebellum. And then there's this thing called Gourmand syndrome. You don't need to really think about it. It isn't common, but it can relate to passion for gourmet foods and other things. Adiposopathy stress cycle is kind of summarized here. Chronic stress, behavior changes, and endocrinopathies and immunopathies occur. That leads to increasing body fat, worsening adipose tissue function, obesity, adiposopathy, and metabolic disease, which leads to more stress, and you get this cycle of adiposopathy. All right, so that's the pathophysiology. Let's talk about patient evaluation. These are the things you would want to get in history when you're talking to somebody about when you're going to work with them on their weight. They look very much like things that you would ask in just a general subjective part of the assessment. Nutritional history. What about their meals and snacks? How often do they eat? What kinds of food are they eating? What's their eating behavior like? Are there other behavior? Previous attempts to lose weight and change body composition, if unsuccessful or unsustained, what were short and long-term barriers to achieving it? What are triggers? What about nighttime eating and binge eating and emotional eating? Family and cultural influences, community influences, and readiness for change. You really need to know all of this about somebody if you're going to be effective in helping them with their nutrition. What about records? Do they keep a food and beverage diary, including the type of food, beverage consumed, 72-hour recall? And the other thing I would put here, although I didn't put it in this slide, is do they know how to read a food label? Very few people do, it turns out. People who have good health literacy still don't know how to read a food label. And the thing that people in my practice don't know, aren't attentive to, the marketers do a disservice because they will have a prepared food, frozen food box of something, lasagna, say, and they'll put prominently on the label 500 calories. And so the person says, wow, I can have all that lasagna for 500 calories. You flip it over, and the food label says 500 calories per serving, 2.5 servings per container. And people don't read that. So they think they're getting a much lower calorie consumption with that product than they really are if they eat the whole thing. So it's that kind of stuff that you have to worry about with people or help them with anyway. Worrying doesn't really help. Get a physical activity history. One of the things people like to talk about when they're doing a project with you or trying to improve their weight is they're just going to exercise more. It's important that they exercise. It's really important that they exercise. The problem is it's almost impossible to affect weight reduction through exercise alone. It's going to take diet. And so you kind of, in the approach you want to do with people is to not in any way diminish their interest in physical activity, but to gently also let them know, yeah, we're going to have to look at the caloric intake as well if we're going to make any progress. But physical activity is good. There's a whole separate lecture we could do on the current discussion out there in the literature about fit versus fat. Some people, it turns out, have high BMIs and high percent body fat, but seem to do really well. They just seem to thrive, and they don't have all the metabolic problems, and they don't have all these other things that I've been talking about for the last 35 minutes. And so it's an important thing to find out, but physical activity is clearly a part of the process, and it can help to mediate some of the problems that they will have with cardiovascular illness and musculoskeletal illness. Routine preventive medical care, make sure that the individual is getting all of the things that they need in terms of breast self-exam, pap smears, testicular exams, and so forth, immunizations, the appropriate health screening, and their vital signs. Need a comprehensive exam. So then you're going to get some labs, and you're going to look for these things in their labs. All of their blood fats, the liver enzymes, uric acid, TSH, vitamin D levels, and there would be a separate little line here. If you think in a female they may have polycystic ovarian syndrome, then you would add on LH, FSH, a couple other hormones that slip my mind right at the moment. But individualized testing is important. So these are things more specific. We're going to look at fasting proinsulin, not an easy test to get, depending on where you're working. But you can get it, for example, from Quest. It's expensive, but it's generally covered if you code the patient for obesity. C-peptides, insulin, if hyperinsulinemia is expected as a secondary cause, like with an insulinoma, dexamethasone cortisol suppression testing, the prolactin, estradiol, follicle stimulating hormone, and so forth, and pregnancy tests in women who have unexplained lack of periods or no periods or irregular periods, the androgens, apple lipoprotein B is an important thing to get, especially if the triglycerides are elevated, iron studies, and the highly sensitive C-reactive protein for inflammation. Some people get MRI computed if the brain, if a structural lesion of the pituitary or hypothalamus is suspected. Now you got to understand, we're now talking about populations that would be very, very rare, epidemiologically rare. About arresting electrocardiogram, stress echoes, ABI, sleep studies, anaerobic threshold testing are all important parts of the full workup. I'm going to look at body testing, individualized, the body composition. You can use imaging. You can also use a tape measure. And I would say in our practice, we're going to be using a tape measure and get a lot of very good information. But there are tons of things. Some of these are almost research level. But we're also looking at, leptin was seen. Leptin's thought to be a appetite suppressant, naturally occurring appetite suppressant released by fat cells in the body. And maybe 15 years ago, everybody was very excited at the idea that if we just gave people leptin, that we could help them achieve weight reduction and lose their appetite to a reasonable extent. What we found out is we very quickly accommodate the higher levels of leptin. So if you give somebody leptin, it'll work for a very short time, and then they just kind of go through apogenesis to just their homeostatic level changes, and they just tolerate higher and higher levels of leptin, and it loses its impact. But in any event, leptin and adiponectin are things that can be looked at. Certainly not everybody in a primary care practice is going to get this kind of a workup, but it is important to know that. I guess the reason I'm telling all this is to give you some concept of just how complex obesity is. It's really, really complex. All right, treatment. Here they are: nutrition, physical activity, behavior therapy, pharmacotherapy, and bariatric surgery. So one you want to figure out is how much do they have sick fat disease or adiposopathy? And you treat excessive body fat, which treats the fat mass disease. The fat mass disease, remember, is the consequences to other organ systems as a result of having too much fat in the body, whereas sick fat disease is something wrong in the fat tissue itself. Treating diseases due to increased body fat and its adverse metabolic and biochemical consequences may improve patient health, quality of life, and body weight and body composition. So there's a lot of good that come from it. Conditions that may promote fat mass gain would be genetic syndromes. We talked about that. Medical conditions, and psychological and behavioral conditions. So those need to be addressed and treated if you want to achieve better weight. Cardiovascular meds, diabetes meds, if you've worked with diabetics, I mean, one of the things that it is not uncommon with diabetic patients, particularly those who are getting insulin, to kind of pressure the provider to achieve a better blood glucose, an A1C or whatever, by giving them more insulin. I mean, that comes up pretty often, actually. And then you have to have this long conversation about, no, I can't. Generally, these people are diabetics who are obese. They may not be type 2, they might be type 1s. It could be type 2s that have converted to insulin. But they just say, well, I'm trying to eat less and I can't. So just give me more insulin. Well, you can't give them more insulin. It's just going to make them fatter. So, this is a conversation that you just keep having to work with. These are things that, however, may decrease body weight. Good old metformin, you can get a 10% weight reduction with metformin. GLP-1 agonist and SG sodium glucose cotransporter 2s, these SGLT2s, and all of these help to, these are diabetic meds, but they also help in weight reduction. So there are things you can do to help. We're going to get to meds a little later. So here's metformin. Has a lot of benefits. Not always tolerated, though. People don't like the GI impact. Other things to look at: hormones, anti-seizure meds. These are all things that can have an impact on it. Things that can increase body weight. We all know the tricyclics are notorious for it, but also some SSRIs and other mirtazapine, for example, has big weight improvement. But what could decrease is Wellbutrin, bupropion. We use it for weight reduction. Variable effects on body weight. Oh, I'm sorry. This is just details of the first slide. Mood stabilizers, migraine meds, antipsychotics, hypnotics, HIV meds, definitely. And they really change fat deposition. People get a lipodystrophy with a lot of the antiretrovirals, where they start making basically lipomas all over their body and in unusual places. So, it's something to be considered. Chemotherapies, oddly, may increase body weight. There are people who gain weight during chemo. General nutrition. So you're going to talk to them about their protein intake, fat intake. A good target for fat intake in people is to try to get them to 40 grams of fat a day. That's going to be a real push, but they'll be healthy. You don't have to worry about getting them undernourished. 40 a day would be great. Down here, it says USDA for fat is at least 30 grams a day. So try to shoot for 40. Carbs, about 130 grams a day. It is a required macronutrient. I'm not going to get into Addison diets and all these carbohydrate, can't think of the current one out there, but I don't use that in working with patients generally, unless that's what they want to do, and then I'll kind of let them try it for a while. I let them. We work together. But in any event, the really low carb diets have some problems with them, not so much with cardiovascular disease, but sustainability and rebound later on. Insulin controls fat metabolism. It promotes fatty acid and triglyceride synthesis and storage, and it inhibits fat breakdown. Foods that cause a rise in blood glucose, like starches, sugars, and amino acids, will stimulate the secretion of insulin from the pancreas. A diet that lowers the amount of insulin is beneficial for weight loss. Kind of going back to high fructose corn syrup again. You get those big boluses of carbohydrate coming in, your insulin level shoots up, your liver starts trying to turn everything to fat, and you just get on this nasty little cycle of weight gain and fat increase. So you're going to try to have people limit highly processed foods to a minimum of nutritional value. Sweets, junk foods, candies, cookies, chips, McDonald's, basically anything you get at fast food. Energy dense beverages. This is my favorite because it's pretty easy to get people to do this. Drinking sugar sweetened beverages like regular pop, juice and cream are high density beverages, and people can make this conversion pretty easily from the sugar sweetened pops to just sparkling water with a little flavoring in it. The diet beverages, I'm really recommending them a whole lot, but it's better than sugar sweetened beverages. The thing is that they seem to set up cravings for other things, well, the aspartame and all that stuff. They probably aren't harmful. It's sure better than drinking. And people will come in and talk to me, they'll come in with a BMI 45 or something and find out that they're drinking a liter or more of sugar sweetened beverage, Coca-Cola, a day. We can get 500 calories out of their diet today boom, if we can just get them to convert to something that they can find that they like that doesn't have all that sugar and that high fructose corn syrup in it. Encourage healthy proteins, vegetables, green leafy vegetables, fruits, berries, nuts, all that. Complex carbohydrates. Glycemic index, don't have time to talk through that, but it's out there. Be sure to get some familiarity with it. So when you're talking to people about what foods they should eat, the glycemic index is a great guide. It's used in diabetic management, but it can be used for everybody, because it matters how that carbohydrate is wrapped with a protein or a starch. Starch is a carbohydrate, but the sugars, so that a calorie isn't necessarily a calorie in terms of its impact of fat genesis. That's why nuts have a lot of calories, but they're slow to be absorbed. And peaches, are different than cherries, they're different than grapes. The calories might even be equivalent, but the impact that they will have on fat generation is different, and it relates to their glycemic index. The glycemic index tells you how quickly the carbohydrate is going to show up as sugar in the bloodstream. That's what the glycemic index tells you. If it's high, it's rapidly turned into blood sugar. And if it's low, it's slow. So that's kind of the difference. And you want to keep people at the low end of the glycemic index. So factors related to improved outcomes: evidence-based, quantitative, qualitative, patient preference, and patient adherence. So choosing nutritional therapy for obesity, the most appropriate nutritional therapy for weight loss should be safe, effective, and one which the patient can adhere to. I worked with a woman, a nurse. I didn't work with her. I was a student in a clinic, who had this belief that everybody should be on a macrobiotic diet. And if you're not familiar with the macrobiotic diet, it's a pretty hard diet to stick to. Very, very, very low fat, other than animal, very low animal fat, lots of plant fat. It's really not, to most of us, not a very appealing diet. But it is really effective in improving cardiovascular health. So she was just so determined that all of her patients who had cardiovascular risk were going to become accustomed to eating a macrobiotic diet. She just, it never happened. It just never happened. But she would not give up on that idea, because in her mind, that was the best thing. And her job as the professional was to tell them the best thing to do. I think that's missing the point. You can offer that information, but the best thing is something somebody can stick with. That's the best thing. It's got to be healthier so they get improvement, but something they can stick with. So these are just things to consider. Eating behaviors, cultural background, to offer information to people that have all these competing forces that will drive them away from the plan you're trying to create with them is doing nobody any good. I mean, it's a waste of your time and an irritation to your patient. And I just don't think I can't recommend doing it. So choosing approaches to weight loss should focus on 3 macronutrients: protein, fat, or carbohydrate. Very low calorie diets, under 800 calories, not something we do in primary care, okay? These people have to be monitored really closely. I mean, like blood work every week. There are people where this makes sense, that they have to get weight reduction this fast, but they should be managed in a weight reduction program. It is a specialty, you refer to this. And to have people on 800 or less calories a day, they can really get into metabolic messes very, very quickly. So you have to be very careful. But a range of 1,200 to 1,800 a day usually can create at least 2.5 pounds of weight loss in people per week. And they can tolerate this well and usually can live with it if you help them with food choices. Restricted dietary fat leads to greater reduction in total LDL cholesterol, where restricting carbohydrates leads to a greater reduction in serum triglycerides and an increase in HDL. Reduction of carbohydrates can lead to a greater reduction in serum glucose and hemoglobin A1C. Nice slide, you can come back to it. I'm not going to spend more time on this. We kind of talked about it. I'm not going to say more about the really restricted low-calorie diets other than they just aren't something that we should be in primary care. We're not equipped in primary care to really deal with them. We don't generally have the nutritional support in with a clinical nutritionist. It's expensive, and patients may not have insurance coverage to do all of the monitoring they need to do. But more than anything, you really need to have specialists in this treatment. But if you have somebody who is in deep trouble with fat mass disease and they got to get some weight off fast, this is an appropriate treatment. It is just not something we should be doing on our own. We should be referring into a program. So where would you find a program? Henry Ford Health System has a great one. I suspect there's one at Beaumont. I know there's one at the University of Michigan in Ann Arbor. They're around. Okay. So restricted fat diet, pretty easy to do. You can take this one down. Patients can learn to live at about 30 to 40 grams of fat a day, but it's going to take some changes for some of your people that like French fries a lot, or a lot of salad dressings and avocados and things that people think are healthy eating, which maybe, but for them, if we're trying to get them down with fat reduction, they're going to have to make some changes here. Here are some that really do work pretty well and people can live with. The Mediterranean diet, pretty darn good. Over time, this one has really sustained people at getting their weight down and maintaining it, because rebounding is a big problem, of course. DASH is great for hypertension. It restricts both sodium, calories, and fat. Commercial diet programs are fine. They're expensive, and they don't always have a long-term success rate, because if you're using one where you're actually getting your food product from the diet program, they're shipping you the meals to your house or the little shakes and all that stuff, eventually you're probably going to have to stop, right? You're going to go back to just going to the grocery store and getting your food, and then people have a way of just pounding weight back on really quickly. So I'm not saying you wouldn't want to use these. I'm just saying you got to plan ahead and know, well, what are you going to do? And there has to be a guided transition out of the commercial product and back into eating just in the community without that source of food. Not surprisingly, the commercial diet programs don't really help with that, because they like having you in the program. ADA and American Heart have some great diets, and I told you already about the Prevent T2 diet from the Diabetes Association. It's really good. Let's talk a little bit about physical activity. So if they have the sick fat disease, they need assistance with weight maintenance and weight loss, improved body composition. These are things that will happen from physical activity. Improved adipopathic physiological disturbances. So there's a benefit that comes from activity to the metabolic activity in the body. And non-adipose health parameters would be improved metabolic health, improved musculoskeletal health, improved cardiovascular health. We kind of know this. It doesn't have to be a heck of a lot of physical activity, just some, so my approach is really guiding people to just do a little bit more every day or 3 times a week or whatever they think they can do. Evaluation to ensure safety is a concern. And so you would look through these things on this slide to make sure that you aren't pushing somebody who's at risk into an activity plan that places them at greater risk. So simple assessment on mobility. A priority is increasing energy expenditures. So dynamic aerobic training and resistive training both have a role. The aerobic training is good to help with changing their metabolic profile, the metabolic activity, and helping them just burn calories. Resistive is good because if they can start building muscle mass, that muscle mass is going to help overall with the metabolic rate in the body. Emphasizing core muscle exercises is great. People want to get their biceps big. Bicep is a tiny little muscle. It isn't very big. You get your quads big, you get, your core muscles big. That's a big muscle mass. If you can get some growth there, you're getting a much bigger change metabolically in your body than necessarily the ones that look great at the beach. You know what I'm saying? That people are really focused on wanting, men in particular, in my experience, want to have big biceps and big shoulders. Yeah, okay, but those muscles aren't very big. leisure time activities, get off the couch, engage in non-competitive sports, things that they like to do. Now remember, if these people are really obese, they are very reluctant for very good reasons to go out and do a lot of activity, because every time they're in front of people, they feel like they're being judged. And in fact, they probably are, sad to say. So you got to really work with them to figure out, well, what are things you could do? Or, where would you feel safe working, and safe from a psychological safety point of view. Transportation, occupation, non-exercise activity, short walk distances instead of automated transportation, take the stairs, carry overnight bags instead of using rollers. These are just little things you can do to increase it. And tracking your progress. Here's one thing I want to spend some time on, and then I'll wrap this up. Motivational interviewing is an approach that I am completely committed to in dealing with a lot of patient issues, in particular this population, and was a big part of my project. So motivational interviewing is a module coming up in this course. So we're going to spend time on motivational interviewing later on. I think it's like week 10 or something. But just for now, as it relates to obesity and nutrition, when you're talking to people about their weight, keep in mind that this is an enormously uncomfortable conversation, not just for your patient, but for you, because it's so stigmatized and people feel shame about being overweight. So your approach to it, to be successful, is to keep the communication open and not let them shut down. If they shut, and not to cause them to shut down, not so much to let them, but not to, you don't want to be a threat. And there's no lecture they haven't already heard. You haven't got anything new to tell them in terms of lecturing them about self-control and being disciplined. Those words are like knives to these people. So you have to be careful. And I think this, in my study, was the biggest barrier we found to why do providers not follow evidence-based guidelines for their patients. And it's because they feel uncomfortable. They don't want to hurt their feelings. They don't want to expose their own biases. They don't want to do things that would be harmful to their patients. Good. But, in the words of one of the primary care providers that were in my project, he said, just give me the words. I don't know what to say. Well, this gives you the words. So this is what we used. This is one tool within this whole toolbox called motivational interviewing. Always ask open-ended questions. Affirmation, affirmation, affirmation. It has to be relevant and genuine, but it has to be abundant for these people. Reflections, careful listening can often be more effective than any form of empathy. And when you're doing this, if you're doing it well, because you're, say, in a face-to-face encounter with a patient for 10 minutes, which may seem like a short time, it's a long time. 10 minutes is a long time to be face-to-face in a visit. Because if you think of even a generous visit of 30 minutes, the actual time you're face-to-face in a 30-minute visit, in my experience, is, if you're lucky, 10 to 12 minutes. The rest of the time, they're still in the waiting room. They're getting weighed by the medical assistant. They're waiting to get a blood draw. They're this, that, and the other thing gobbles up all your time, and you just get a few minutes. So one way to tell if you're working well with reflections is that if somebody videoed you while you're in that room with them for 10 minutes, for at least 9 of those minutes, your lips are not moving. I have to suppress my urge to keep offering my wisdom to people. Oh, I can help you. Oh, I can help you. I'll tell you. And I have to really work with myself to shut up and just sit there and listen. That's a very powerful form of empathy. And if you've never tried it, you're going to be astounded at how effective it is. At least I was. I keep thinking I'm supposed to answer things. And even, they'll pause and kind of look at you. Just keep looking at them, keep this, a pleasant, neutral look on your face. A little nodding to show that you're relating is fine. But that reflection is so powerful. I guess as a race, we just don't often get to tell our story without having it interrupted. And, oh yeah, I know somebody else who did this. And, oh, I have patients who this worked for them. That comes later. Right now, you just listen, okay? And then summaries. Once you get through that, you kind of just try to reflect back what was discussed and shifting from the negative past failures toward more positive future goals and establish some metrics. That all can happen in a very short period of time. Most of the time should be listening. Okay. And I should shut up and listen. Move on. All right, here's another one. Frames is a good model. Feedback about personal risk. Hey, have you thought at all about, your weight is this and your height is that, and so this, that, these are the facts that we can see here today. Has anyone ever talked to you about what that might mean in terms of your long-term health? That would be feedback about your personal risk. I have some information. Do you care to hear it? Responsibility of the patient isn't you're responsible for this. It's like, what can we do to help you achieve what you want? Advice to change, menu of strategies, an empathic style, and then supporting self-efficacy. That's the frames model. I actually don't use frames, but it's good. 5 A's is really common in addictions, but it works well in obesity as well. Ask for permission to discuss body weight. That is so important. And you know what? Once in a while, people say, not today. And you know what you say? Okay, maybe another time when you come in, we could do that. And you just move on. You don't try to convince them. If you do, you've lost the game. Ask for permission. And if they say no, you respect that. You can explore readiness for change, the trans-theoretical model. So then you do an assessment. You advise them on what you found. You together with them can maybe agree on some realistic weight loss expectations, some behavioral changes, things that will work for them. And then you arrange and assist. Figure out what does their insurance plan cover. People are, health literacy being what it is, people don't know what their health insurance plans cover. And so I get on the phone when I have a moment, not right then at the visit, but I get on the phone and say, you're right, I'm, you're insured as a patient with me, blah, blah, blah. This is who I am, and this is what I want to know. What do you have? And sometimes you have to be pretty darn persistent and advocate for it. Isn't there anything else you could do? Are there any alternatives? Is there a prior authorization process? It takes some time, but it's what they need. Another one focused on motivational entering is collaboration, working together. Evocation is a big one. Drawing out the patient's thoughts, evoking, not telling them what to do. And autonomy, empowering the patient to their own solution and not an authoritarian power clinician, because that's played out in their lives so much. You're not offering them much of anything. These are the principles of motivational interviewing. Express empathy. Avoid augmentation, making things bigger than they are. Augmentation. Develop discrepancy. This is what you want, but this is where we are. Not in a, oh my God, isn't this awful stage, but there is a discrepancy. Without a discrepancy, why was there a need for change? Resolve any ambivalence and then support self-efficacy. We all have ambivalence. If you ever stopped smoking, if you've ever had to live through that or made a change of any kind, you're going to have ambivalence about it. And that's not a bad thing. That's just the way we are. That's a reality. So just, unfold it, get it open so that you can look at it together. Resistance. Yeah, it happens. Resistance, changing behavior. Types of resistance: arguing, denying, ignoring, and interrupting. What do you do with that? You roll with it. Rolling with resistance avoids arguments and confrontations by choosing not to challenge the patient's actions and statements that suggest resistance to change. And this is especially useful at the beginning. And then the therapeutic paradox. This is one I'm careful about. I don't think I've ever really done it. Let me explain role for resistance. There's a thing called drumming. Drumming is another one. We'll probably get this when we do the whole module on motivational interviewing. Drumming is this concept that when people are talking about weight reduction, in this case we're talking about, and they say, well, I did these positive things this week, then you're just quietly going, oh, that's great. Oh, wow, that's, positive. Doesn't have to be effusive and just, yeah. Go, good for you. This is great. But that, that wasn't hard. That must have been difficult. And I'm really gratified to know that you did that. Then they say, yeah, but then I sat down My friends came over and we ate 2 bags of chips and drank 3 liters of Coke. You don't say anything. That's rolling with resistance. Or I just can't do this. You don't react. It's impossible for me to lose weight. Nothing. Zip. Nothing. Not judgment, not a scowl, nothing. No response. Next thing they say is something positive. Yay. That's drumming. Works great. You'd be surprised. Okay, therapeutic paradox is analogous to reverse psychology. The people say, oh, I don't know, I just got my kids, my this, my job, my one, and you would say, oh, well, it just sounds like this must not be the best time, hoping that they're going to go, well, I don't know, maybe I could. I'm just a little afraid that I'm just supporting their negativity. So I have a hard time with therapeutic paradox, but it's out there in the literature, and I have an obligation to tell you about it. Reflection. You don't think you can lose weight right now. That's kind of the Carl Rogers approach to empathy, just reflecting back, keep reflecting. Amplified reflection, people worry too much about your weight. Your current weight is not really a problem. No, it's an amplified reflection. Amplification, you're a little careful about that one. Double-sided reflection. You had previously suggested you were committed to weight loss, but now you no longer feel the commitment is necessary. So that's kind of part of role with resistance examples, reflecting it back to them, shifting the focus, reframing, and siding with a negative. Those are all things you can do with resistance. Ambivalence, uncertainty in the desire for change. Identify the discrepancy, amplify it, make it a little bigger. Now, here's one place where amplification isn't quite so difficult to manage. It may facilitate thoughts of change. Oh, you feel kind of ambivalent. Wow, this must be a real conflict for you. You're kind of amplifying the discrepancy so that they react to it and then resolve the ambivalence, help them figure out a process where they can get out of that uncomfortable position of feeling ambivalent. Here is our old friend, the trans-theoretical model, and you can incorporate that with motivational interviewing. It seems like maybe you're just, and then you kind of reflect, but remembering letting them talk, you're talking maybe certainly 20% or less of the time. They're talking, you're listening, and then you can kind of frame what they're saying for them to approve or endorse or not endorse in terms of the trans-theoretical model. Elicit talk of change. That's a good one. Why do you want to change? How important is that change to you? What do your actions fit with your values? And you need to use language that's natural to your patient. And you're going to have to figure that out. Query extremes. How accurate is that statement? Because people tend to talk in extreme measures. Supporting self-efficacy. Here's some examples. You've lost weight. What do you think were the main things you did to achieve this? How do you feel about your success? Let them start talking that. You want this positive self-talk, and then affirmation, really important. Advice and feedback and summary examples. Okay. What do you know about how body fat can affect your blah, blah, blah? Advice and feedback. Summary. From what you've said, you want to lose weight mainly because you're concerned about your health and because your family's concerned. That's a summary. It seems that your commitment to weight management plan with the support of your family, most everyone agrees that overall you're making great progress. These are all summative processes that you can use. Behavioral therapy, I'll just touch on it. There's psychological things. Why do people eat like they do? So we just left motivational interviewing. We're moving on to psychological behavioral therapy. So this is just helping people change their behaviors. Here's some physiological aspects and timing and emotions. Why do people eat like they do? These are triggers to eat. And, we got to have triggers to eat. You can't, we'd be dead very quickly if we didn't eat. Environmental triggers, information gap, lack of education about proper nutrition. It's real. It's out there. People don't understand it. These can all be why people eat like they do. They just don't even understand that eating all the things that they're eating is really harmful to getting them where they want to be. And why do people eat like they do? More rewards, a lot of this. It also has a physiological, neurological response to eating, especially chocolate, sugars, high-fat foods. We get an opioid release out of it in our brain. The locus ceruleus responds to this very well. much like it would to alcohol or drugs. So there is a, if you will, a high you get from eating that piece of cake. I mean, it really does have a neurotransmitter connected response. Here are the things that really do work well with behavioral therapy: binge eating disorder, night eating disorder, and bulimia and nervosa. So night eating disorder, there are people, we call them nighters, is kind of the slang term for them. At least 25% of their calorie food consumption, or sometimes more than 50%, is consumed after their evening meal. Now, this assumes they're on a day-night regular schedule and they eat 3 meals a day. And then after that, at night, before they start sleeping, they just consume a vast amount of food. It's a known behavioral pattern that can lead to a lot of weight gain. Recurrent awakenings from sleep that require them to go back to sleep, often involving carbohydrate-rich snacks. They go down to the refrigerator, they go down to the cupboard, they're eating, carbohydrate-rich snacks. So just let it go with that. Night eating may occur in as much as 5% of the population, and the treatment is a behavioral therapy regarding nutritional timing and content. There's binge. Did I go past binge? Okay, well, binge eating, I don't see a slide for binge eating. I thought I had one in here. Binge eating are people will, no kidding. I mean, if you talk, maybe we have binge eaters with us today, and this isn't judgmental, but it's just surprising if you aren't a binge eater to know that there are people who will consume enormous amounts of food. And I'm not talking about people who are then going to vomit it up, the bulimic, but who just do. I mean, they get 2 large pizzas and eat all of them in a setting, or will eat, a gallon of ice cream. Is just, not unusual. And when you think about the impact that has on their ability to maintain a healthy body weight, that's just huge. So they need some help, and behavioral therapy can really help them with that. Cognitive behavioral therapy in particular is really good about thinking it through, slowing down the thoughts, dealing with the cravings, how long does the craving last, which is about 15 minutes, that kind of thing. And then bulimia, nervosa, people, you'd say, well, they're vomiting. Yeah, they're vomiting, but oftentimes they can remain, you may see bulimics at any BMI range, all over the place, but it's an eating disorder. So we're talking about obesity today. There are bulimics who remain obese. You need to find them out, and it's dangerous. It's a really dangerous. You want to get them into specialty care with psychiatry, but also offer other things that you can do from the primary care standpoint as well. And why don't people engage in physical activity? Well, here are the reasons. Just interest, lack of interest. But keep in mind that if you have a really high BMI, you're going to be it is very likely your patients with a high BMI are going to be fearful of being out in public or being in a place of physical activity because they don't like to showcase their body. And that's going to require some talking and finding safe ways that they can be active and not, oh, go ahead, don't worry about what they think. Is just a waste of your time to say stuff like that. And it isn't very kind. So, I would hope that you find ways to do it. I worked in one clinic where we had a walkers club where people could come at any BMI. Mostly they were high BMI people. And we walked on Saturday mornings. Things like that can be done. There are creative things you can do. Why do people regain weight? Well, here's physiological and neurobiology reasons. Here we have on the physiological priority imbalance. Neurobiologic processes strongly resist starvation. Neurobiologic processes weakly resist overnutrition. So you're going to be more than likely to overeat than undereat if you're given choices and there's food available. And then the neurobiology is that leptin, insulin, cholecystokinin, and peptide Y all encourage weight gain. Weight loss may decrease these endocrine factors, which in turn may increase your appetite. Weight loss may increase with ghrelin, which in turn may increase appetite. and poor restorative sleep can be a part of it. I don't want to waste time on that today. So behavioral therapy techniques should be doable, practical, measurable, and be heavy on self-ownership. This doesn't sound a lot different than what we saw in motivational interviewing, but these are more behavioral activities, whereas MI is more about letting someone find the things they want to do and helping them strategize around action plans that are implementable for them. So here are some specific behavioral therapies: stimulus control, avoid eating for reasons other than hunger, kind of thinking it through, cognitive restructuring, addressing matters of body image, identifying, establish a plan to counteract unhelpful or dysfunctional thinking. There's a thing out right now, a program called NUM, N-O-M. It's all based on cognitive restructuring. That is a cognitive restructuring program. If you want to see one, Google NUM and go look at their website. That's what they do. They help people think differently about their eating. It's cognitive restructuring, and it does work. Goal setting, self-monitoring, behavioral contracting, and problem-solving, social support, and other reinforcement contingencies, which is much like the 5th A and the 5 A's. So little things right here at the end: self-management technologies, things to think about. Social media, websites. I have on my phone an app called MyFitnessPal. I record my dietary intake on that, and I track my weight because I can gain weight so easily, and I don't want to be have a BMI higher than I do. I actually like to get about 5 pounds off right now. Let's talk about obesity meds. This is surprising to me. Providers are really, really reluctant to use obesity medicines when they are clearly indicated and the evidence is there that they can help. Yet people restrict this option from their patients. So everybody with a BMI over 30, which is a lot of people, meet FDA-approved anti-obesity medication indications, and people who are overweight with a 27 BMI with the presence of complications may benefit from anti-obesity medicines. And if there's no clinical improvement after 12 weeks with one anti-obesity medicine, consider alternative therapy to more than one. What I commonly heard in doing my study and in just my general relationship with my colleagues is people say, well, I don't like to use those. And it just makes me want to scream. I want to say, well, they like to use antihypertensives, hydrochlorothiazide, geez, I don't know, if they just ate less salt, geez, this is a serious illness. We should be treating this. So here are some examples. Before 1990 or before, phentermine, diethylpropion, I don't know what that is. Oh, benzamphetamine and orlistat. Orlistat. God. And examples after. So there were some out that caused some problems a while back, about 25 years ago. That is dogged all of them. But there's lorcaserin is an anti-diabetic med. A lot of these are. Naltrexone and bupropion alone, phentermine and phentermine topramate, extended release. I use that. Adipex, that's known as, and liguratide. The problem with many of these meds is that insurance coverage is limited on them, but they can work, and they work really to get people started. If people get enough self-efficacy rolling and they can get a 10 or 15 pound weight reduction, no matter what their starting point is, they have a lot more motivation and a lot more power to continue in their course of weight reduction than trying to get past that first 10 pounds can really be hard. These meds are really good for that. They can't stay on them forever, but it's a great way to get started if they're appropriate. And I don't do it first step, but it is on my in my toolbox, and I pull it out much more frequently than a lot of people do, and I have not so far had any problems. Bariatric surgery is a real option for people to consider if they have BMIs over 40. Most guidelines will say over 35, but generally it's over 40. And it's kind of the same thing. It will modify their eating behavior because they can't eat large meals. Their dietary restrictions are rather severe, but the results are quite remarkable. And you will see people with regaining weight after bariatric surgery over time, stretching their sleeve and so forth. But, you know, this obesity is killing them. Don't lose sight of that. Even if we get them 10 years of a better BMI and eventually they regain, I hope that doesn't happen, but if it did, it's still a good thing to do. So I would not be cautious about it. If it's indicated, at least send them for a referral if they're interested. If they don't want to do it, then find other things they can do. So here it just shows you BMI over 35 with one or more associated comorbid conditions are here. A BMI over 40 without, or people can be considered. And the other thing is would have insurance coverage for it. So here's kind of what we've been talking about. Assess the presence of obesity. These are kind of the things you would look for. Obesity, it's just prevention. Encourage healthy eating. Overweight, treatment is ineffective. Refer to obesity specialist, certainly possible. Primary care provider or dietitian. And then obesity here in these ranges. Oh, the Edmonton obesity staging system, it's just a staging system. It's nothing you really need to remember in particular. It would be used in bariatric surgery programs in particular, use it. But it's a way to tell you what's going on. And it may be a way to have conversations with patients who are willing to talk with you about it in terms of their risk. It does stratify risk really well. Going to have evaluation and treatment summaries and individualized plans. This shows you the potency, lifestyle modification, lifestyle with medication, very low calorie diets. We know the problems with those, but they are a possibility, and then surgery. Now, that was a lot. Why in the world would I take you through all this physiological information in a health promotion class? Well, the health promotion message is this. When you have a patient, increased health risk due to overweight and obesity, and your intervention is to say, you should eat less and eat better foods, or you should exercise more, you have completely blown it because you completely discount the challenge these people face. That is not helpful. Do not simply say, well, you just have to eat less. What I hope you got from today's lecture was how complex this problem is. And, this is transferable to a lot of nutritional disorders. It's really tough. It's a very complex disease. It has a lot of factors in it. And so, if you just kind of come in with this self-satisfying approach of, here, let me give you a pamphlet and you ought to eat better. You leave the room thinking you have done your job and you have alienated that patient. It just happens all the time. And I hope you can avoid falling into that trap that's so easy to fall into, because it leads your patient to feeling, again, like they failed. They came into a healthcare environment and they got told they were fat and it was their fault. That's what they hear. And you are going to have to work to get over that history. And it's a problem that can happen with a lot of health promotional things. Stop smoking. Don't you know that's bad for you? God, yes, of course they know that's bad for them. You have to engage people. And you don't want to let them get to forget it. Some of your patients may use a different F word there that's vulgar, and I'm not going to say it. But when they get to that point, oh, forget it. You've lost them. So the strategy is to keep them working with you. Just keep them working with you. Don't let them get to forget it. Because once you get to forget it, they're going to go home and eat 2 pizzas and a bag of chips somewhere. Whatever, that's a stereotypical thing. But I mean, that you haven't helped him. You probably made him worse. You certainly offended him, and you have reinforced the stigma. You've done all the things you didn't want to do. Just you got to put the judgment away. Focus on what they can do. Give them information. And my advice overall is motivational interviewing and a diet they can live with, and exercise that will make sense for them and that they have the courage to do, and loads of information. affirmation. So that's that. I think we're done. Understand the disease. That would be one thing. Really get to understand the diseases that you're trying to offer health promotion about. Use motivational interviewing techniques. Listen to your patient's experience. Listen. Suppress your need to be brilliant. Talking to myself here. Got to suppress that urge to just tell them everything that's going to help them. Just listen. Affirm your patient's efforts so far. Ask them if they want to hear information. Like, gee, I think sleeping around unprotected sex with 15 partners in a month might be a problem. I have some information out there. Would you care to hear it? If they say no, then you move on. Same thing with obesity. Educate yourself about the evidence-based guidelines. Educate your patient about strategies that can help. Plan with your patient in the driver's seat, and you have to help them. Be their advocate. Once you have a plan, you help them implement that plan to the best you can. Boundaries needed. They have accountability. I'm not saying they don't, but there are things they don't know. So those are the things you should be doing, like dealing with the insurance company. All right. What do you want to say about all this? Nothing? You got nothing to say about that? Okay, we got some chat coming in. You guys can unmute and talk. Yeah. Well, I hope it's helpful. I just used obesity as one way to talk about health promotion for nutrition, but it is a hugely important thing right now for us in the developing countries, not just in the U.S. But my greatest concern is the kids. That trend line on kid obesity is just horrifying, and it's hard to turn it around. I am encouraged by the flattening of the rate of increase. So let's hope it's all going to be done. Oh, good, you have, Laura. That's great. Good. All right, everybody. I'll let you go. I know you got patho or something coming up here in a few minutes. So hope that goes well, and I'll see you on the discussion board.